Hello, my name is Christopher Seymour. Thanks to the organizing committee for the opportunity to join the conference today. Excited to talk in the COVID-19 therapies section about targeting TLR4. I'm an associate professor at University of Pittsburgh and a member of REMAP-CAP. And excited to address this topic. So a few disclosures to start. I do receive funding from the NIH and IGMS. And have had personal fees from the companies listed. And notably, I'm a PI on a COVID-19 trial inside REMAP-CAP addressing these areas, receiving no individual support for that trial. Okay, so some caveats to begin. Any talk that has the title of TLR4 in it might have one thinking that this is going to be heavy on immunology. But in fact, that is not my background. I am a clinical translational scientist. And so I have some understanding, and we'll be discussing some things about the biology of sepsis and COVID-19. But we'll also note that this is evolving, and it's possible that as we're recording this in August, we may have far more knowledge about many of these issues when the conference happens in September. So thanks for your patience. Okay, so let's get into it. It's just going to be a short talk, about 10 minutes here, thinking about this mechanism as a potential COVID-19 target. So I just want to give one or two slides here showing that we are in the process of knowledge generation about the immune response to COVID-19. This is a fantastic paper by a huge team in Science. I think that was just published a few weeks ago, looking at different immunotypes or immune phenotypes based upon flow cytometry studies in patients with COVID-19 compared to other conditions. So this is a very complex slide. I think it's worth showing that not all patients with coronavirus have the same immune response. And there's space validity to this, but this is quantitative and visual data that's confirming that. You know, it's also notable that Manu Shankar and his group at Imperial College London had this paper in Nature Medicine, also released in mid-August, again showing that there were 2 to 3 immune phenotypes that were present that correspond to different cell types and their activity at different times in COVID-19's disease. So, you know, we won't at all go through the details here, but this work ought to suggest to us that the immune response and immunomodulation is a potential therapeutic avenue that's worth exploring. Now, it may not be in the end that all patients receive the same type of immune modulation. In fact, these two slides and these beautiful papers would tell us that that is probably not the case, but we'll discuss more in a moment. Okay, so at the same time that our translational and basic scientists were showing us all of this beautiful, complex data about the heterogeneity in SARS-CoV, we also had this trial and many others that were published just this week in JAMA. So this comes from REMAP-CAP, and what it's showing is that in approximately 400 patients with severe COVID-19, most of whom who were receiving organ support, when randomized to hydrocortisone or not, had markedly different outcomes. And in fact, this was a Bayesian analysis, and you can see that certainly patients that received hydrocortisone had a 93% chance of an improved outcome versus those that did not. Now, when Derek Angus, who's our department chair and colleague, mentor, and a leader of REMAP-CAP with many others, including Steve Webb, Colin MacArthur, and a broad international trial steering committee, he was discussing these results with the lay press. And as he was going about his explanation, he was sort of describing corticosteroids and coronavirus like this old Ford car shown in the drawing at the top of the slide. It is a way to get from A to B that's not very elegant. In fact, it'll get you there, but it may not be pretty. And in fact, we may not know exactly the specific mechanism that these corticosteroids are using to improve outcomes. On the other hand, many of the thousands of COVID-19 treatments that are proposed are a bit like the Lamborghini shown on the bottom. And that's the case that they're specifically targeting an individual biologic mechanism involved either in viral entry or in the host response that may reduce the amount of lung injury present in severe coronavirus. And so we're sort of stuck saying we have evidence from this fantastic set of trials and meta-analysis that the Ford is going to work and save lives. And so what do we do with all these other Lamborghinis, perhaps being tested in trials or proposed to be tested in trials at the same time? So I guess it's worth thinking, well, what are the unanswered questions? If our patients who are severe are all getting Decadron or hydrocortisone or Solumedrol, what else do they need? And so when we think about who was included in those trials, of course, moderate patients were not tested. And so what about immune modulation in the moderate patients? At the same time, should we combine anything with steroids? What's the scientific rationale for giving a specific molecularly targeted treatment against one bit of the immune response when we're already giving a reasonably moderate to high dose of corticosteroids? In addition, the trials that we just discussed only gave treatment for about 7 days. And so what do we do afterwards? Is there any role for immunomodulation afterwards? So as you might expect, there's a lot of choices. Now, this is confidential data from the NHLBI Active 3 Prioritization Committee. That's why the slide is blurred out. But what it's showing is that there are lots of choices for immune modulation, far more than I could fit on one slide or could even understand all the mechanisms that have been proposed. It is overwhelming, the number of molecules that are proposed in different pathways to modify the variety of immune responses that occur in coronavirus. So how do we choose? And why would we choose just one? So this is a schematic. Actually, it's a beautiful cartoon from Joost Wersinga, Hallie Prescott, and others that was published in JAMA in one of the most cited clinical reviews of COVID ever. And it's showing a bit about the pathophysiology of early stage COVID-19. And as viral entry occurs and pneumocytes are affected, there is a host response that involves T cells, monocytes, neutrophils, macrophages. And though this is a viral pneumonia, there's a very set of traditional cytokines that enhance that inflammatory response. Now, it's notable that cytokine storm that's been talked about for months has in fact not been borne out in recent studies comparing these COVID-19 patients to others with severe sepsis. Nonetheless, one might ask yourself, what about TLR4? And amongst all the mechanisms, of course, we would think about this, in part because when Beutler discovered this, ultimately, this knowledge led to the Nobel Prize. So it's an incredibly well-studied and understood signaling pathway. It's a pathogen recognition receptor and typically would be involved in the response to LPS from gram-negative bacteria. The TLR receptor and family of receptors is found in a variety of dendritic cells, mast cells, neutrophils, and others. And, it participates in viral infection. And so there's two examples, and of course, there's many more. And of course, I'm not a virologist or immunologist. So forgive my naivete with some of this, but there's been this interesting hypothesis generating work looking at the structure of the spike protein on the coronavirus and seeing how it may or may not interact with TLR4 and propose that it actually could. Now, similarly, folks have been studying TLR4 inhibitory molecules or antagonists for years. And in particular, iridiren is one in which we're most familiar with. So this is a synthetic molecule. It's derived from what's called the lipid A component of non-pathogenic LPS. And here it's a beautiful study in Nature almost 10 years ago, looking at an influenza murine model, where in fact E5564, which is the name of iridiren, had lower clinical scores shown in the upper right panel post-infection. That's a clinical scores higher when it's worse, and improved survival in the Kaplan-Meier curve on the left, and suggests that although TLR4 may have a classic role for the non-immunologists as it relates to LPS and gram-negative bacteria, in fact, this is a mechanism that's at play in viral infections as well. So, well, what about the clinical trials? So the good thing about iridiren as it relates to TLR4 is it's been tested in thousands of patients. And so led by Steve Opel and a large group of collaborators, the ACCESS randomized trial enrolled patients to receive iridiren if they had severe sepsis, evidence of organ dysfunction, and elevated Apache 2 score across hundreds of centers. Now, the results of this trial were a bit disappointing. So when you look at these Kaplan-Meier curves, both for 28-day survival on the left, as well as 1-year survival on the right, in fact, there's no difference between eritrea and placebo. And so this drug at the moment is not being used in clinical practice for severe sepsis. But what might this look like in COVID? Well, we've just said that most severe patients will already receive a very broad affecting corticosteroid. And so perhaps it's actually in moderate patients that eritrea or TLR4 pathway drug might be tested. As we've seen both in recovery as well as REMAP-CAP, using Bayesian adaptive designs can potentially find answers efficiently. And so perhaps that might be a reasonable thought. And in fact, it might spare patients being randomized to arms that are actually not improving outcomes while also generating knowledge for future patients. Perhaps because Access has already tested it around thousands of patients, we'd use the same exclusion criteria, an international study, and of course, probably try to use the same dose. So it's worth just touching briefly on this issue of an adaptive trial. And so there's been a variety of reviews written on this subject and a greater familiarity of our field with what these novel clinical trial designs are, in part because the FDA is also advancing them beyond just oncology, but in other fields, and particularly in coronavirus. And so what this means is that there's a model developed before any patient is even randomized to a treatment. And that model sets up decision rules throughout the trial so that as the dice is rolled or the coin is flipped when patients enter the trial, over time, that coin may be weighted to one arm or the other, depending on how the treatments are impacting outcome. And in fact, we're weighting patients' randomization to the arms that tend to perform better. And that's what's shown in the schematic down at the bottom. Now, these adaptive trials can potentially have a shorter enrollment time. They can perhaps be less costly, but they involve a far more statistical burden on the front end, and also relate to the number of treatments being tested. Sometimes these adaptive designs are no more efficient when only A is being tested versus B. So this is worth understanding a bit more about as the adaptive designs become far more common. So the last bit was safety. Many of the molecules being proposed as immune modulators in COVID-19 actually haven't been put into humans before, or have done so only in phase 1 or small phase 2 trials. The beauty of something like eritrea that acts on this common mechanism is that it's been put in thousands of patients, and this is the safety table from the appendix in Access, which actually showing that rates of these proposed adverse events such as hypokalemia or atrial fibrillation were quite similar across the groups. Okay, at the same time, and full disclosure, I'm involved in the design of a trial using this drug. It's quite possible this might not work, and that's why there's equipoise. In fact, moderate patients might not be the correct target phase of the illness. If your loved one was on 10 liters of high flow oxygen, would you really want them to get this novel infusion? I don't know. It's also true that as we learn more about the different immunophenotypes, as shown in the beginning, about COVID-19, there may be specific groups in which this drug might work better and others in whom we might know in advance that it might not. There's a variety of logistical barriers to new drugs like this. They can require special handling, special infusion methods, and as we touched on in the beginning, the treatment effect itself may be fully overwhelmed by the steroid therapy that might occur as the patient enters a severe state. So I guess to just wrap up and conclude this very brief discussion of the TLR4 mechanism as a therapy for COVID, I would say that in general, immune modulation is not dead. The recovery and REMAP-CAP, the Brazilian trials have not stopped our pandemic science. In fact, it's prompted us to think about many more questions other than just that brief period in which the patient may be receiving steroids. Could eritrea be a candidate? It's being loaded into REMAP-CAP along with many others into an immune modulation domain. There's the ISPY to COVID network that's also doing phase 2 trials of a variety of immune modulators, as well as a proposed active 3 trial from the NIH. And finally, I'll just add this a picture of Janet Woodcock. She's been a fierce advocate for novel trial designs at the FDA, that these must be considered to generate rapid new knowledge in the midst of a pandemic. So thanks for your attention and look forward to the discussion.